So I've started recording. All right, well, maybe we'll just get started. I think people are trickling in, but I've got a nice long intro, so we won't miss it. So good afternoon, everyone. It's such a pleasure to welcome you to Alberta Wide Nursing Rounds. My name is Lindsay Komar, and I'll be your moderator for today's Zoom session. So we're very excited to continue our 2026 rounds, which are now going to take place on the third Thursday of every month at noon. So please note that we're no longer meeting on Tuesday evenings. And sometimes it won't be on the third Thursday when we have to change things up. So, just keep your eye on the advertising. Thank you all so much for being here, and we'll get started. So Alberta-wide nursing rounds builds on the foundation of our longstanding citywide nursing rounds, which was an initiative that has connected nurses, students, educators, and researchers here in Edmonton for many years. But now we're expanding our reach. So by going province-wide, we're creating a space for nurses from all corners of Alberta, urban, rural, and remote, to share knowledge, raise questions, and build community. So this is about amplifying the voices of nurses and ensuring research and practice truly inform one another. These rounds are about more than just sharing findings. They're about tackling real world issues you face in clinical practice and celebrating the impact of nursing scholarship. So before we begin our session, I would like to take a moment for a land acknowledgement. The Faculty of Nursing at the University of Alberta is located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, and Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. We recognize the First Peoples of this land, and we commit to working together toward reconciliation and equitable health outcomes for Indigenous communities. So just one quick housekeeping item before we begin. Our session is being recorded. I believe the recordings are posted on the website, but email us if you ever have trouble finding them. So today we are celebrating Wear Red Canada Day. So that was actually last week, but we're celebrating today on rounds. So on February 13th, people across Canada wore red to raise awareness about women's heart and vascular health. And we're going to contribute to that effort today by featuring nurses who are conducting research in women's heart health. To kick this off, I'd like to introduce Dr. Colleen Norris. In her addition to her role as Associate Dean of Research at the Faculty of Nursing here at the University of Alberta, Colleen is a registered nurse and a professor in the Faculty of Nursing who holds the Carvazan Chair in Women's Health Research. Today, Colleen will tell us about the incredible work she and her team are doing in women's heart health. We will hear from all of our presenters, and then we can open the floor to questions for those who are able to join the panel. So I will hand it over to you, Colleen.
Thank you so much, Lindsay, as usual. I am so appreciative to be able to highlight the work that our research team is doing in women's heart health. And it's really, on the weekend when we had our Wear Red Gala, I was just so incredibly proud because of all the volunteer students and people that have assisted in moving this women's heart health forward. But one of the things that I recognized is maybe one of my skills is surrounding myself with really brilliant women who will take this message forward. And I just say women because actually I don't have male students right now, but males are always welcome, obviously. So it's going to be the different projects that people are working on or looking at as we move forward. And I'll start by introducing the first one, Jenna Semmens, who did her BSCN with us and in the honors program, started her master's, and now is a PhD student. Went through the fast track to doing a PhD. So she's now a registered nurse, and she's a PhD with the Faculty of Nursing. And she is supervised by myself and Dr. Gillian Lemmemeyer. And her research is focusing on women's health across the lifespan, with particular attention to midlife women's experiences accessing healthcare in the perimenopause, really the perimenopause stage. And she's using mixed methods approach to examine healthcare system navigation and unmet care needs among Canadian women in midlife. So I'll turn it over to you, Jenna.
Hi everyone, good afternoon. Thank you so much for coming for our nursing rounds today. My name is Jenna. I'm a nurse and I'm also a PhD student with Dr. Colleen Norris. And I'm going to tell you a little bit about my thesis project looking at women's health in midlife. So, my overarching research question is, how does the presence of an ACE, which is an adverse childhood experience that we'll talk about in a minute, influence the healthcare utilization experience for women in midlife? So there's going to be 3 phases guided by 3 separate research questions for this thesis project. And I'll get into these questions at the end of the presentation, but I wanted to add them on this slide as well. So I'm going to start this presentation by kind of defining an adverse child event or experience, healthcare utilization, and what I mean by women in midlife. And then I'll go a little bit into my study design and these specific questions. So adverse childhood experiences they can be things like abuse or neglect, and they correlate with poor health outcomes throughout life. They're also more commonly seen in women than men. And people who have the presence of an ACE are more prone to comorbidities like hypertension and diabetes, as well as coronary heart disease, as well as accelerated biological aging. They're also more likely to cancel or miss healthcare appointments. So that was kind of something that stuck out to me when reading up on this, that they were less likely to access healthcare, even though they seemed to need it more because of those comorbidities. So what do I mean when I'm talking about healthcare utilization? Well, healthcare utilization, there's 4 dimensions: service availability, the barriers to access, relevance and the effectiveness of the service, and also equity. So my project will cover all 4 of these as I go through it. I'm also going to use the Anderson Healthcare Utilization Model, which was created in the 90s. And it covers these 3 types of factors that can affect healthcare utilization. So predisposing factors, which in my study are going to be gender, age, and ACEs, and sex and gender. Enabling factors, such as having a public healthcare service system or living in an urban environment, and then need-related factors like having a chronic illness like hypertension, diabetes, chronic kidney disease, that type of thing. So I want to kind of explain as well what I mean when I say midlife women. So there was a conference done in 2001 where essentially they staged the reproductive aging of a woman's of a woman's life. And the late reproductive stage is kind of after what we would consider peak fertility, but before perimenopause and menopause. So it's typically between ages 30 and 50 years old. That's a pretty broad age range, and that's on purpose to, make sure we're really capturing this demographic. Women in this life stage often do face increased demands at home while balancing a lot of different stressors. A lot of women are returning to work after caring for children, or they're having children, or friends of people around them are having children. Oftentimes, they're trying to advance their careers in general. That can be very stressful. Managing aging parents, aging family members, that can be very stressful. So there's a lot of life stage stressors at this phase, but there's also physiological changes happening with their hormones. So we know that there are subtle changes to the hormonal cycle seen during this stage that can create some pretty unpleasant symptoms, such as, fatigue, not feeling like myself, being maybe a little bit more easy to anger, those types of things that are very subtle, but they are changes. So that taken together can create quite an impact on the health and well-being of these women. So why do we care? Why does this matter? So evidence has linked ACEs to poorer healthcare care behaviors, as I discussed before. A gap also exists in healthcare utilization during these years because women are so busy taking care of everyone else, it seems like. And it's also very important to note that this is a critical time in a woman's life to influence change of behavior. Either correcting symptoms because there's something else happening underlying, or promoting better healthcare behavior, lifestyle changes can influence the health and well-being of women in their 7th, 8th, 9th decades of life. And this is really important with bone health and heart health. So thinking of things like osteoporosis, if we can reduce a hip replacement, that's a huge, huge change for that person to try and prevent, that very invasive surgery. So a bit about my study design. It's going to be a mixed methods explanatory sequential study, which means we start with the quantitative, analyze that data, and then go through the qualitative, analyze that data, and then combine it at the end. So the quantitative phase is going to be a survey that we have been collecting data for already through the YEG Women's Research Registry. I'm going to be looking at some of the sex and gender questions, the ACE presence questions, and some of the symptom presence seen in those women. The qualitative phase is going to be art-based focus groups, and the women will be divided on presence of an ACE and not presence of an ACE, so we can compare the difference there. They're going to essentially kind of follow like a craft night model where all these women come together to make a craft and promote, be in community with one another. And we're going to use the art and the dialogue as evidence for this part of the study. So once again, these are the phases. So it's going to start with a scoping review that we're working on already, where we're looking at how women are currently utilizing the services during their midlife period. Phase 2 is that quantitative phase. Phase 3, the qualitative, and phase 4 is the integration. And you can see here that those are the questions that are going to guide each phase of the study. So thank you very much for listening to a little bit about my study. If you have any questions, I am more than willing to reply via email. So there's my email there. And thanks again for coming to the rounds. We're happy to have you.
Thank you so much, Jenna. That's a lot that's going to be done, and I'm really excited about it. I'm going to introduce our next speaker, who is Sela Scott. Sela is actually not here right now because she's in Hawaii helping her mom get married. Sela Scott, who is Shannon Scott's daughter, actually is doing a master's in medical sciences, obstetrics and gynecology with faculty of medicine and dentistry. And she holds a bachelor of science in honors in psychology. Her research is focusing on women's experiences of reproductive aging as well, and particularly in menopause. But she is leading our project called Aura, which we have developed, and it's going to be in conjunction with our new clinic that we've opened, NP-led virtual clinic for women in the perimenopausal stage. But she is, Aura stands for Awareness and Understanding of Reproductive Aging, and it's a digital intervention for perimenopausal and menopausal women in Alberta. And it's going to be evaluated in a clinical trial to assess its impact on menopause knowledge and menopause-specific quality of life. And we've really identified that women just don't understand the stage and what they're going through, and it's been medicalized, and we don't want to do that anymore. We want to make it a natural process and have women understand what they're doing. So now we'll hear from Sela.
Today, I'm going to discuss Aura, an upcoming project using a digital approach to enhance women's primary care across Alberta. To better understand Aura, I will briefly explain some of the other work that is ongoing in our lab and plays a role in Aura itself. First, the Cycle Cessation Registry, which serves as a foundational data platform collecting women's lifelong sex and gender-related health information. Second, the Alberta Women's Cycle Cessation Clinic, which is virtual and NP-led that supports women through reproductive aging. Now, Aura is a digital app that serves as a companion to the virtual clinic. Together, the clinic and Aura work in parallel to support women, combining clinical care with accessible educational support, while the registry captures the broader data needed to understand reproductive aging across the lifespan. Aura is composed of 4 pillars, with knowledge and education as a central component. A primary focus of Aura is education, providing women with clear, evidence-based information about reproductive aging, including what's happening in their bodies and why symptoms occur, as well as how to manage some of these outcomes. Weekly modules will include a short and comprehensive video, as well as additional resources to support learning, including podcasts, reader-friendly research articles, and condensed information sheets. Topics in the education pillar will include neuroendocrinology, cardiovascular health, urogynecological health, sexual health, hormone therapy, gastrointestinal health, and menopause myths. The remaining pillars, nutrition, mindfulness, and physical activity, have optional components. These components are designed to complement the educational content and reflect a whole body approach to reproductive aging, recognizing that this transition affects multiple systems. Together, these pillars allow Aura to offer flexible, personalized support while keeping education at the core of the experience. To evaluate Aura, in combination with the virtual clinic, we are using a prospective, pragmatic, controlled trial design through the course of an 8-week intervention. Roughly 750 women will be recruited from across Alberta and will be allocated based on their timing of entry into the clinic to one of 3 study arms. The first arm is clinical care only, serving as our control. The second arm combines clinical care with Aura, and the third arm receives Aura only for the duration of the study. It is important to note that the participants in the third arm of this study will actually come from the waitlist of the clinic, so they will receive clinical care after the point of the intervention. To evaluate Aura, we collect data from 4 key sources. First, participants complete the cycle cessation registry, which provides a comprehensive picture of their historic health data, including their life experiences, biology, and access to care. Second, quality of life is assessed at pre and post using validated measures. Third, Aura will collect a vast range of data, including physical activity logs, user engagement, pre and post quizzes assessing their knowledge, and much more. Finally, clinical health records will allow us to understand the therapeutic interventions that participants are receiving and the menopausal symptoms they are experiencing. These clinical health records will be tied to the virtual clinic and shared with us upon consent of participants. In summary, Aura is an evidence-based, expert-led digital intervention that is designed to be accessible and inclusive for midlife women. What makes this program unique is its integration with the virtual cycle cessation clinic, creating a combined approach where digital education and clinical care work together to support women through reproductive aging. Delivered digitally, Aura is scalable across Alberta. We hope to recruit roughly 750 women between the ages of 40 and 60 into this clinical trial. The intended outcomes include increased awareness and understanding of reproductive aging, improved menopause-related knowledge and confidence, support for symptom management, and an overall increased quality of life, all while contributing valuable data to women's health research.
Wow, that was just, oh, I'll put my video back on. That was just brilliantly done. I was just thinking I should have added the presentation into my CIHR grant. People can see it in pictures instead of listening to all of our verbatim. Our next presenters are Shanzay Mehrani and Tori Gagne, who were 2 of our nursing honors students who worked with us. Shanzay's in her final year of the after degree nursing honors program at the University of Alberta, and Tori is completing the after degree nursing program at the U of A and holds a bachelor's degree in human biology. I should mention Shanzay had a bachelor's degree in science and cellular microbiology. Shanzay and Tori Honors Project was involved in developing Edmonton-based community resource guide to support a randomized controlled trial that we are doing, examining adherence to guideline-directed medical therapy amongst women. And just to give a bit of a brief talk about this study, we are looking at women who attend the heart function clinics in the city of Edmonton, so at the Mazankowski and at the CK Huey. And we are looking at the use of a social prescribing, which is a model used in the NHS in the UK. And it's a person who has is not necessarily a social worker, but undergraduate work in the social work field. And is we provide women with using the Spark tool, we collect information on the social determinants of health that they may have issues with, and they will be provided with a social the social work, not social worker. I just forgot the name of what it is, what her title is, but she will help them with resources in order to improve the care in the heart failure clinic. social prescriber. And one of the things I was just talking to Lindsay about it this morning, and one of the things that's really interesting to me is one of the women in our study is 2 months behind in her rent. And that's the area where this woman, our social prescriber, will be able to help her with assistance in that area. Because of the resources that were gathered over the project of our nursing honors students. And I think we forget in our system that people have to deal with their life before they can actually come in and get the excellent care that we can provide. And we've known for years that our heart function clinic, if people follow it and follow the evidence-based care and monitor their weight and their everything that's going on in their life and come in for the clinic visits, that they will improve their outcomes. But we totally neglect the fact that they might not be able to do that until we help them to be able to attend the clinic. So I'll turn it over to Shanzay and Tori to explain how they developed the huge amount of resources that are available for our social prescriber to use.
Hi everyone, I'm Shanzay and this is Tori, and we are second year BSCN after degree honors nursing students. We're supervised on this project by Dr. Colleen Norris and Nicole Tegg, a PhD candidate. Our project focuses on heart failure, which is the second most common cause of hospitalization in North America. One of the biggest challenges is poor adherence to guideline-directed medical therapy. This is especially concerning for women who experience higher mortality and morbidity from cardiovascular disease. Women are also underrepresented in clinical trials, even though heart disease can present differently compared to males. We know that social determinants of health, such as financial, physical, mental, and social needs, are strongly linked to poor adherence, worse outcomes, and a reduced quality of life. To help address these barriers, social prescribing connects patients with community and non-clinical services through a link worker, providing psychosocial support to bridge the gap between medical and social care. This project is part of a multi-site randomized clinical trial, which means participants are randomly assigned to either a control or intervention group across multiple locations in Montreal and Edmonton. The intervention group includes a link worker who supports participants in managing the SDOH that were affecting their medication adherence and quality of life. The study is titled Social Prescribing to Improve Outcomes and Adherence to Congestive Heart Failure. The research question asks, can social prescribing through individualized referrals to community supports improve adherence and quality of life in Canadian women with heart failure who are at high risk for non-adherence? The primary objective is to determine if social prescribing can reduce hospitalizations and deaths in women with heart failure and improve adherence to pharmacological regimen. Tools like Spark Questionnaire is used to identify these women at higher risk of non-adherence, making it possible to deliver targeted interventions.
Next, we'll go over our research deliverables. We found resources and organizations for Edmonton and Alberta to guide the link workers' social prescribing. This was titled the Edmonton Community Resource Guide. This was similar to an environmental scan. We attended meetings throughout the preparatory phase to learn more about the preparation of a study before participant recruitment. We edited and reviewed documents in REDCap to prepare for data collection and will contribute to writing the introduction and methods for this study. We'll go over what we enjoyed and learned. We enjoyed collaborating with the Research Institute of McGill. It allowed us to explore differences in research between provinces. We liked finding resources that are available in our community. This will be beneficial in our nursing practice and future clinical placements. Lastly, we enjoyed observing how a study adapts and changes and how challenges are navigated between different researchers and institutions. We learned about the complexity of research before a study can proceed. For instance, challenges associated with getting ethics approval and approval to hire the required personnel for the study. We learned about the challenges associated with working in a multi-site study, as different teams can be at different stages. And lastly, we learned about the ethics approval process and navigating site-specific software for U of A that was ARISE. Looking ahead, next to be explored in this study includes data collection and entry into REDCap. We hope to be part of analyzing and interpreting data. We want to know about the effectiveness of a link worker, how this service benefits patients, and the ability to incorporate this service into nursing. Lastly, we're excited to explore the process of collaboratively writing between different sites and provinces. Our outcomes is that we expect a co-authorship for an expected publication. We expect to have a deeper understanding of the research process from approval to interpreting data. And our last outcome is to be attentive to the effects of social determinants of health and how to include and address these aspects in nursing care. Thank you for your time. Here are our resources.
You can see what I mean by surrounding myself with really brilliant women. It's just amazing. These studies, I love seeing them like this. So our next presenter is Dasha Bosyy. And Dasha contacted me after she started her first year of medicine. And she is a registered nurse that's always worked in cardiac care and works in our cardiac intensive care unit in Edmonton and was working in Calgary. And she's now a second-year medical student at the U of A and continues to practice as a registered nurse. Her clinical experience spans public health, internal medicine, and critical care. And Dasha's research looked at the relationship between arterial stiffness and sex and gender-related factors that influencing estrogen levels in women, with the goal of improving cardiovascular disease prevention, prediction, and treatment. And I have to say that Dasha had the most unique combination of skills when she first came to us, because right now for women, one of the measures of poor cardiovascular health is a thing called arterial stiffness, but it takes an hour to do arterial stiffness measures. And it actually should be done on all women because we know a certain level of arterial stiffness is indicative of future cardiovascular problems. But as you can imagine, there's no physician that's going to be doing arterial stiffness measures in a clinic because it just takes too long to do, and it's not viable at this point in time. So we purchased the machine, and it was so fortunate to have Dasha because you need a nurse to do the measurements. And so she was able to recruit and do the measurements and complete the study virtually by herself. Her recruitment was unbelievable to me because she just put posters up everywhere that she could imagine. And we had women, we were booked up for women to do this study. And it was asking a lot of them too, in order to come in during their day and do it. So we're learning as well all about, there's this myth that women don't like to participate in research. And my response to that is women really love to participate in research, but we haven't made it easy at all for them to do it. We'll say, we're doing our study on Wednesdays at such and such a time, can you come in? And it doesn't work for them. So part of the thing that we did for this study was we created an app where they could pick, Dasha would identify when she would be there, and they could pick the times that they could come in. So I think that was really helpful in our recruiting. So we'll turn it over to Dasha.
Hi there. My name is Dasha Bosyy. I'm a registered nurse working in cardiac intensive care, and I'm also a second-year medical student at the University of Alberta. This past summer, I had the privilege of working with a wonderful team led by Dr. Colleen Norris, looking at women's cardiovascular health, specifically the relationship between arterial stiffness, sex, and gender factors that affect estrogen levels. So why is this research important? Well, cardiovascular disease continues to be a leading cause of death worldwide. There's been numerous research studies that have looked at the risk factors and complications of cardiovascular disease, but most of these studies were done only on men. Recent data is suggesting there's a significant difference in the way that females develop, present with, and experience cardiovascular disease. One of the reasons for this difference is estrogen. Estrogen is a key sex hormone in females and has been shown to play a protective role against cardiovascular disease due to its role in maintaining vascular elasticity. It makes sure our vessels are nice and stretchy. Estrogen levels, however, vary day by day, with age, with medication, and with different lifestyle choices. One of the biggest things that affects estrogen levels is the perimenopause transition. This usually occurs between the ages of 35 and 55, and at this point, estrogen levels steadily decline. This means that we don't have as much protection from estrogen, and therefore our vessels start to become stiffer and the cardiac risk increases. Unfortunately, there's not a lot of data out there about what that increase actually looks like and how we can screen women and account for this risk. So that's where our study comes into play. We were aiming to create a registry that explores the relationship between arterial stiffness and those sex-related factors in women going through the perimenopause transition. By recruiting 123 women between the ages of 35 to 55, we invited them to participate in a 1-hour in-person appointment. At this point, we measured their height, their weight, their blood pressure, and their pulse wave analysis and velocities. Pulse wave velocity is what we use to look at arterial stiffness. We managed to get a physical measurement for that. And then after the appointment, we invited them to complete an online survey that looks at the factors that affect estrogen levels. So things like, when did you start menstruating? Have you used any hormonal birth control? What are your stress levels like? All of those things that I brought up in the graph before. Now we are in the process of comparing the data from arterial stiffness measurements and the survey to see if there are any correlations between them. One common question I was receiving about our research is, why not measure estrogen levels using a blood test? It's a really good question, but unfortunately, it's not that simple. As I mentioned earlier, estrogen levels vary day by day, and there's quite a significant change throughout a menstrual cycle, not to mention the big fluctuations during perimenopause. And so a measurement at one point in time doesn't tell us much about the overall trend. We're hoping that by using a more qualitative approach, we can tease out the more complex relationship of estrogen and arterial stiffness. During the appointments, I was also receiving lots of feedback from women who are very thankful that we're looking into this stage of life and creating conversation about the topic. Most participants who are going through perimenopause voiced frustration about the lack of knowledge that their physicians have about menopause, the symptoms that go along with it, and what they can do to support them. I'm glad that I'm part of a team that's taking on this underserved topic, and I'm thankful that there is increasing interest and awareness about the importance of women's health. I'd like to thank you for taking the time to listen to my presentation, and I'd also like to thank the sponsors that made this research possible. I would not have been able to do this work without them, and I'm looking forward to continue to see what our results are while we analyze the data. I hope you have a great rest of your day, and I hope to see you soon. Bye.
Dasha was incredible at, as I mentioned, getting this done, but also all the help from Maya in our office and Nicole and the various people that were involved in the study. So our last presenter today, last but never least, is Nicole Tegg. And some of you may know, but I met Nicole when I taught the stats course in undergraduate school. She was doing her BSCN in nursing. And she really liked research, and I ended up hiring her as a summer research assistant, and she carried on and she finished her BSCN, and then she ended up doing her master's while having a baby and COVID, which was just unbelievable to me to watch. And then she applied for and got into her PhD and is now working on her PhD. And through all of this, I have to say that Nicole has really shaped how I think about things, because she would come to me with questions or articles that she read, and I would just really get me thinking, and we'd have discussions. And it really, honestly, the one article that she sent me that changed my life, or that we talked about, was when we were talking, she brought a study that it was postmenopausal women, and they were both had exercise regimes, and one had estrogen, was given estrogen on top of the exercise regime. And the most interesting thing to me about it was there was no benefit to the exercise without estrogen. And at the same time, Nicole and I were both part of what's called the Canadian Women's Heart Health Alliance, and we were working with women of lived experience, and we've known for a while that women present differently as far as their cardiac health or their cardiovascular health is concerned. But these were women who were fit and non-smokers and not big drinkers and ate the right foods. And more importantly, they all were exercising. And some of them would say, but I was a long distance runner or I was an athlete. And Nicole and I had a discussion about what do these athletes and menopausal women have in common is that they don't have estrogen, because typically the athletes or young women who are dieting or even on birth control pill don't have the endogenous estrogen that they need to repair to keep their vessels healthy. And we do know in the literature, and Nicole did a chapter in a book about it, estrogen's benefits for the cardiovascular system. And one of the things that it does is it maintains your cardiovascular health by keeping the vessels pliable. It gets rid of the bad fats. It's an antioxidant, it's anti-inflammatory. And so young women who have amenorrhea or a loss of a period for more than 3 months don't have the benefits of that estrogen. So that's what Nicole started to investigate in her study. So all that's to say that she's a registered nurse, clinical background in maternal health, and she's in her 3rd year of her doctoral candidate here at the U of A Faculty of Nursing. She's collaborated on all sorts of studies with the Heart and Stroke Foundation of Canada, the Canadian Women's Heart Health Alliance. And her patient-partnered mixed method doctoral research is examining the relationship between missing menstrual periods prior to pregnancy and the development of heart-related pregnancy complications. So take it away, Nicole.
Thank you, Colleen. I'm going to share this as a PDF. I'm hoping it will share. Okay. Can everyone see that? Okay. So this is kind of the more lay-friendly title of my project, but missed periods and heart-related pregnancy complications. There's been some recent literature, and they're now titling them CARES, or cardiometabolic associated reproductive events, which I feel like encapsulates what they are a little bit better. So, as Colleen mentioned, we were looking at this relationship between missing menstrual periods before pregnancy, and this is 3 consecutive cycles or more. There's been some recent research coming out just in the last couple months saying that we probably actually don't have a grasp on the prevalence of this because it relies on a lot of factors. So this is kind of based off of like small studies and the available data. There's a lot of reasons that women might not report their periods, especially when we look at the current political climate. But these are kind of the best estimates of the prevalence right now. So in the general population, it's thought to be about 3 to 14%. In women with things like PCOS or polycystic ovary syndrome, about 10 to 20% of women are affected by this. And they found, and this doesn't have to be elite sport level participation, this can be recreational or higher level sports participation, but in endurance sports, so biking, running, about 40 to 56% of those women may lose their menstrual periods, and it is associated with estrogen deficiency. So then when we look at these cardiometabolic associated reproductive events, these include gestational hypertension or high blood pressure in pregnancy, preeclampsia, eclampsia, gestational diabetes, preterm birth, low birth weight, and placental abruption. And importantly, these increase the mother's risk for premature cardiometabolic morbidity, which is a public health issue. There's also risks for the baby as well, and it affects their like long-term growth and development, and especially with the preterm birth and low birth weight, the risk of being admitted to the neonatal intensive care unit. So we wanted to see if there is a relationship between these 2 factors. There have been some calls for research to try to identify more risk factors for these, I'm going to keep calling them CARES, but these cardiometabolic associated reproductive events, because the prevalence has actually gone up. So a recent study found there was a 27% increase over a 10-year period in Alberta. And then for the hypertensive disorder, specifically Canada-wide, they did find an increase in those as well, which is concerning. We would think with the more we know that hopefully we could be reducing the incidence of these pregnancy complications. So I did an explanatory mixed methods study. So the first phase was quantitative. We did a Canada-wide survey. We collected women's menstrual, reproductive histories. We looked at their psychosocial gendered factors. So things like level of education, if they have support, if they're the primary person responsible for caring for dependents, their wage, if they are the primary earner, all sorts of those factors, as well as hormonal factors if they were on contraceptives or used hormone replacement therapy. So we used all of that data to build a predictive model to see who was essentially more at risk for developing these complications of pregnancy. And then we took a subset of women from this first phase. We had 367 women from across all 10 provinces respond to the survey, which was amazing. I'm really grateful for all the moms who took time out of their busy days to complete our survey. We interviewed women who had extreme lengths of missed periods within our cohort. So for our cohort, that was 12 months or longer. A lot of those women, it was actually about 5 to 10 years that they missed consecutive periods. So we wanted to interview them to understand what their perceptions of that experience were. This is important for nursing because nurses are well positioned to collect accurate menstrual histories. This isn't really something that's routinely done right now, but I do believe, especially with the integration of Connect Care, that perhaps we could expand upon what we are collecting other than when was your last menstrual period. Finding a relationship between these pregnancy complications and missed periods is important for public health, educating women, educating clinicians, and I think broadly society. These pregnancy complications have both maternal and fetal health implications. And then, as I mentioned, there's been calls to identify additional risk factors, especially for preeclampsia. That one has a lot of significant lifetime risk for mothers on their cardiovascular health. Sorry, I kind of jumped around a little bit, but yeah, so for phase 1, we had those 367 responses, and then we ended up doing 10 semi-structured interviews, which I think were probably the most interesting part of this study to me because what came out in the interviews was not really what I was expecting to find. I thought maybe missing periods for 5 to 10 years, that women might not have been reporting it to a clinician, but interestingly, all of the women reported it to clinicians, some to multiple clinicians, because they were younger at the time of that experience for themselves. The response, and this was across multiple provinces, was, "You're young, do you want to be pregnant?" And when the women said no, they said, "Well, come back to me later when you're trying to get pregnant. We don't need to worry about this right now." So I'm still working on some final touch-ups. I could talk a little bit more about my findings, but being mindful that I haven't defended yet and it is unpublished data, so I didn't put any on the slides. But I think our most important finding, actually, we found there is a relationship between missing menstrual periods for 7 or more consecutive months and developing these complications of pregnancy. Those mothers were about 3 times as likely to develop pregnancy complications, and that was any cause of missed periods. So endocrine causes, functional hypothalamic amenorrhea, which is the overlap of stress, diet, exercise. There were a couple that were chronic disease or a traumatic injury to the head that had caused missed periods. But so regardless of the cause, they're about 3 times as likely to develop the complications of pregnancy. Some of the factors that we found that were associated are things we can't change. Being of a non-European ethnicity, they were significantly more likely to develop complications. The other one we found that we can act on, especially as nurses, was mental health needs. About 30% of our whole cohort identified a score on the Patient Health Questionnaire 4, so it screens for anxiety and depression symptoms that could require follow-up. And about 30% of the entire cohort screened for anxiety, depression, or both, requiring follow-up. And I think that nurses are really well positioned to address mental health needs. And I think it speaks to a lot of unmet mental health needs in our Canadian moms. So I think I'll leave it there unless there's specific questions.
Thanks so much, Nicole. Going through the data with Nicole has just been unbelievable to me because as Nicole said, I had assumptions that for me, and I've made this joke before, it's called amenorrhea because you're saying amen. Because women are really happy not to have a menstrual cycle for aside from being pregnant, of course. And so I thought that, women were, especially the runners and the athletes, where that's fine. It's I'm not going to tell anybody about it. But the women in Nicole's study were very keen to tell someone. But in society, we say if you aren't trying to get pregnant, don't worry about it. And it's really changed my whole message, and all of ours, all of the work that we're doing in women's heart health is that we need to really create awareness amongst younger women from the start about the about estrogen's effect, and why we've changed to this ovaries are the architects of women's health, because estrogen is not just for your heart and brain health, but it is significant for obviously your bone health and for your kidney health. We also know amenorrhea causes issues with kidneys. And women, I didn't even know that. It's only when I went back to the literature to start reading up, and Nicole did her chapter, and I'm saying, oh my gosh, like no one ever told me that estrogen was for your heart health and your brain health. And, as we're going through it, it's been really, really interesting. In all of these studies, you can see that it's observational, and we're trying to collect data from the women. And, there is nothing out there about this. There's virtually nothing. That's why Nicole can do a PhD on it, because no one's looked at it. But also the fact that, if we turn to clinicians or medical clinicians specifically, I want to say NPs are completely different and are really taking this on. But if we turn to medical physicians or clinicians, they aren't taught about this. They don't know about it. And the responses to women are quite dismissive still. And so our whole modus operandum in all of these studies is to say, yeah, it's observational data, but look, no one has collected it. And Nicole has 400 women who reported on this. And, guess what? This is how many of them had amenorrhea. And when she says like some 5 and 10 years of this, like it just blows me away that would be deemed as okay. And so our whole everything that we're doing is to create awareness, and we've had such good experiences with every single woman that gets involved in this. We created a registry to ask all these questions and just put it out there, and it's on our research website, and 500 people have completed it just for the sake of completing it. And one of the best things for our research is at the end, we say, would you like to participate in other research studies? It's like 98% are saying, yeah, please contact me. So it becomes this groundswell of people that, if we have somebody that wants to look at a study that is an intervention for sleep, then we can look at all the women who are saying they're having issues with sleep, and we send them a letter, say, would you like to participate in this study? So from a recruitment perspective, it's been incredible. And I'm absolutely always overwhelmed at the response for research. And I was even on a call this morning, and they were saying, we know that women don't participate in research, and you're just pulling your hair out, because it's like this broad brush that's saying they don't participate. And the best example I have for this is that I was shadowing an incredibly good research study that was going on over at the Royal Alec clinic, and they approached older moms in their 40s who it was their first baby, but they had preeclampsia. And because we know that complications of pregnancy, this has been identified a long time ago, any of the vascular complications of pregnancy, you show up with early heart disease in women. And I'm going to sneeze. But they approached them, and the women were very keen to participate. And so the clinic had a physiotherapist, a nurse, a doctor, a nutritionist, everything that the woman would have, all the resources we could give them to help them stay healthy after this pregnancy where they had preeclampsia. And while I was there, the biggest issue is they had no show rates. And while I was there, the phone rang, and as I said, over at the Royal Alec, and you could hear a newborn screaming in the back. And the woman said, "I've been driving around this effing parking lot for 2 hours. I'm going home." And I thought, there's why women don't participate, is because we are like, who could park at the Royal Alec any time of day, whoever they are? There's lots of myths that all of this research that these wonderful students are doing is starting to dispel, and it's just getting the word out there.
This was so fantastic. Thank you, Colleen, and to all your students. This is so helpful for all of us to learn more about this. I always look forward to this every year, the February rounds. I just wanted to open the floor to any questions for any of our presenters. I know not everybody's here, but I'm sure Colleen and Nicole can answer questions if anybody has any. Oh, Jim.
Hello. Thanks for this, Colleen. My comment is about the first presentation. So Colleen, you might be able to help me with this about the adverse childhood experiences. And coming from a mental health background, obviously, when I see adverse childhood experiences, I immediately think mental health and mental health diagnoses. And wondering if that is, I mean, it's probably outside the scope of the student study, but if there's a consideration around the mental health impacts of adverse childhood events and women, especially with mental health diagnoses, things like trust with healthcare providers, a lot of the stigma and kind of the gaslighting that happens for women in the healthcare system, especially with a mental health diagnosis, which is something that I've seen a lot of. So I'm just wondering if there's opportunity to make that link as well, look to see if it exists.
Yeah, for sure, Jim, and absolutely. I mean, you hit the nail on the head. So that we do collect. I mean, they're really screening tools, right? More than anything else, asking if they had been diagnosed with depression, but also the PHQ, whatever it is, Nicole, but asking them about their depression and anxiety. And the most interesting thing in Nicole's work is that, you know, we always combine those scores, depression and anxiety. And in previous work I'd done way back, women were more likely, in our heart health research stuff, women were more likely to have really significant anxiety levels, like debilitating ones. The men were more likely to score high on our depression screening tool. And so I said to Nicole, we need to split those up. You know, we can't put them together and say, did you have depression and or anxiety? Because they're so different, right? And also in this age group, it's, you know, I can't express it enough, but the late 30s is when, you know, your follicles are really significant, start the big slide down. And so you're not getting the estrogen that you had. And we talk a lot about this with one of my colleagues in Toronto who looks at estrogen and the brain health. And, you know, the first signs that women will show that they are in this stage of life is they report not feeling like myself, but when you dig down, it's incredible anxiety, irritability, and anger, and mental health issues because of the estrogen receptors in the brain not getting the estrogen they need, and estrogen has to work with serotonin. So we need to, and what's happened in the past is that those women were said, it's probably stress and you need to go home and handle your stress. And now we're telling them, I can't tell you when we say to a women's group that it's your biology that's doing this, you know, it's lower estrogen levels. And then to top it off, if you are living in a chronic stress environment, which virtually every woman is, I don't know about men, I just do women. So, so every woman at this age, like when you think between, you know, 35 and 55, highest level of stress in their lives with everything that's going on. And we know that the brain prioritizes the production of cortisol over estrogen. So at a time where it's already running down, you are also tamping it down because you're in chronic stress. And so it's creating mental health issues. And Jim, honestly, it's like 9 women out of 10 will say, if I go to the clinician and say, I'm not feeling like myself, or I even went, you probably heard the story. At 42, I went in and I said, I think I'm going to kill somebody. I really do. Like, I was so angry and irritable all the time. And again, it must be the stress. Let's try you on an antidepressant. And that's what's happening even today in 2026 to these women. And so not only are we not recognizing that it's biological, it's also a mental health issue that needs to be handled. We need to figure out how to handle your stress on top of it. But also it's being dismissed by, I'll give you a pill to take care of it, right? An antidepressant. And again, 9 out of 10 women that go in at this stage will be told you need an antidepressant. And they may need it. For sure, right? But we're not assessing it. So long answer to your question, but yes. So we are collecting those as well as what is your mental health issues right now. And then we're going to look, is there a connection? And in all of the modeling that we do, it's similar to Nicole's work because there's so many things that she's modeling that, we're trying to tease out. Yeah. And the other thing that I just love is because I did an epidemiology PhD and I did modeling. And I remember having these battles at the time because people think that, you put everything in the model and then whatever comes up as statistically significant is predictive of your outcome. And then we've created this wonderful risk model. And actually, it's a really, I just loved it because to me, it was like making soup. You put this in and see how your model changes and put this variable in and put this variable in. And because I had a huge sample, I was able to do that. But what I really recognized is there are clinical things that I know will affect outcome. And whether they come up as significantly predictive or not, they need to stay in the model. One of the things in Nicole's is not white people suffer more. And I can tell you 100 reasons why that's happening in the sense of our system and how we provide perimenopausal care to women. But we need to keep that in, whether it's significant or not, because we need to recognize that that's one of the issues that are producing these outcomes. But the other thing that I've lectured Nicole about is that we can't leave it to a computer to determine what variables are influencing this outcome. And we need to keep our clinical focus to say, but I know this affects it, these social determinants or whatever. But aside from that, people all make the mistake of saying, if it's not significant in the model, then we take it out because it doesn't matter. But as I've said to Nicole, just because it isn't independently predictive on its own of the outcome, it still can be predictive of that outcome, right? And so it's learning those lessons because of all the different experiences we have that we can actually make a difference in this population. And I think that's where nursing research thrives, right? Because we have the clinical experience to say, okay, but this matters. And I'm not, because you produced a model, like all of the risk models that we have in heart disease don't work in women. They really underpredict or overpredict the risk. And that's because we're missing all the stuff that makes the women different than the men. Oh, you're on. Yeah.
I'm out of practice. Thank you for your question, Jim, and thank you for that great answer, Colleen. So I think we better end there because we have 1 minute, but I just want to say thank you again to our presenters and thank you again to everyone who came today. We're really pleased to announce that Jim Johansson is going to be leading the March rounds to talk about wildfire and health. And so registration is now open on the website. So I'm just going to put this in the chat so you can go sign up right now because Jim and I are going to present together and it's going to be great.
And I heard on the news this morning that wildfire season starts March 1st, whether our weather is indicative of it or not. So very appropriate.
Yeah, that's a timely presentation.
One
Yes.
quick question, comment. The website is just being updated. The date is being changed from March 19th to March 26th. So that it just hasn't happened yet, but Celeste posted it, but it's not yet live. So we will wait an hour.
Wait 1 hour and then register.